Good morning. Welcome to our Finance Committee meeting. We do have a quorum, so we're going to get started. I will chair both our planning and finance today, since I'm going to be sitting in for Chairman Patty today as well. And welcome our Vice Chair.
Hello.
Maybe we get started? Your permission? I'm like, how are you? I don't think we have any citizen that wish to address, so I'm going to go with the approval of the minutes. Anybody have any move approval? May I have a second?
Second.
All in favor, signify aye. Any opposed? Motion pass. The next item on here is for the planning agenda. We're going to have A, B, C, and then we're going to move D into executive session, the closed session for discussion, and then we'll come back out for that. So welcome, madam.
Thank you, sir. Good morning, everyone. So item A is an update on the not on there? Okay. So item A is the update on the placemats. And as requested by Board Member Zimmerman, we have gone back and made some modifications to the cash flow diagrams. Again, the blue bars are the quarterly projected spends. The little orange bars that you see next to them are the actual cash spends by quarter. The top orange line is the cumulative blue bars for the entire project. That is the entire budget. And the gray bars are the cumulative spend to date through the quarters. So if you're looking at the PEC, yes, we have not spent as much as projected. We are still on track and on schedule. But it's better that we are underspent right now as opposed to overspent. So we are continuing on that path. Everything else, other than the updated pictures, of course, you can see them framing for some rebar for a concrete vertical wall pour on the lower right-hand corner, but the project continues, and we poured a slab weekend before last, so we're on our way. Second one, Meadowcomb Southwest. We are really moving along quickly on this project. We were a bit behind schedule due to some permitting issues with the city. We have received our grading permit and now our foundation permit. You have a picture of the drill rig in the bottom right. They are trenching the site and putting all the underground work in, and they are moving rather quickly, catching up with those piers to get us back on schedule. So that one is really moving nicely, and I'm excited about that because pretty soon we're going to have a foundation out there and we can start doing the superstructure. And the last item is the temporary lots. We are moving nicely with there. We expect site capture of the parking lots around the PEC for that full scope, and when we do that, we will transition that parking over to the temporary lot A. We are still working on temporary lot A. As of today, that projected date is August 19th. That may move a week depending on availability of certain materials, steel, et cetera, for the rebar for the slabs and the underground pier work at the PEC. So we don't want to take it early. We want to do that timely, as we don't want to have an interruption and have an empty site and where nobody's working. That doesn't make sense for us to do that as an organization. So that's where we are to date on the placemats and the construction projects to date, and they are moving quite nicely. Next item, item A. Oh, yes, sir. Yes, sir.
Do they give you a projection of when they'll start slab?
I know it's in the schedule. I have not seen that, but it's part of the schedule, and I can get that for you.
Is there anything significant?
Pardon?
Is there anything significant for that slab that you want to discuss?
No, I just want to see what their projected schedule. I know he's saying we're moving along fast. I just want to know what they're saying that projected schedule is.
I'll get that information for you. I do know there are 182 piers, and we're about a third of the way through. It's a lot of drilling.
It just seems that when I go by there, I don't ever see anybody there. That's when I was just asking. I'm just,
Right now, we have not started that. We have a warehouse behind the pavilion right now. We are going to be erecting a new warehouse. It was actually cheaper to buy new and build it than de-erect and re-erect. And that will start after we open temporary lot A and do the transition. We're focused solely on this transition first. It will house much of what it does now, our emergency management materials. It will also hold some building materials, doors and things like that, so that they're not exposed to the elements.
Okay.
And that is secured and cameraed, by the way. Okay.
Wait, no, go ahead for the next one, please.
Okay, so we have 4 items. Item D, we're going to discuss in closed session. The first item is recommendation for award for an art consultant. We had 6 respondents. The final 2 shortlist, 2 respondents, both were HUB participants, and we are recommending American Art. This does not go forward to the commissioners. This is one of the enterprise consultants that we have, similar to our civil and other folks that we have done in the past. And we are recommending American Art Resources to the board.
We need to have a motion. May I have a motion for the recommendation, please?
Second.
No. Would you like to move for motion?
second.
Are you moving or
No, I,
second?
I'll move anywhere you want me to.
Zim move and second by Kevin. All in favor, significant aye.
Aye.
Any opposed? Motion pass. Item B, please.
Item B is recommendation for award for architectural and engineering design services for the medical office building. Just a note here, this is our last major A&E recommendation for the entire bond program. So we made it. So we had 11 respondents. Surprisingly, this was our most responded to, not the hospital component, which you guys looked at before. We are recommending 2 firms, Hoffer Welker and Perkins and Will, and both of them had exceeded our HUB participation rate by a large margin.
Have they done anything with us before?
What's that?
Have these 2 firms done any construction with us before?
Perkins and Will worked with JPS in the past. Hoffer Welker is working on the Pavilion North expansion right now, and they're quite good.
So these are the 2 who go to the commissioner court.
Yes, sir.
Did I hear you said they exceeded?
Yes, one was 36% and one was 45%.
That was subs?
No subs, this is for their consultants.
Right,
This
okay.
is A&E.
So they're doing joint when you say exceeding?
Well, they may have civil, electrical engineers, mechanical engineers, plumbers, et cetera. So this is design, not the construction part. The next piece is the construction part.
Right, I asked that because when we say exceed so often, I guess I'm just looking for where there's some joint ventures, whereas we're dividing it more half and half, so.
Yes, sir.
No sub, and they're all in-house.
Differently. Why do we need 2 respondents to be selected?
That has been the process that we've had to send to the board.
Of those that
for
move
each
on
of
to the
A&Es.
court, remember, part of our process, the court is asked to be inserted. I'm sorry, Daphne.
Okay, so this is,
We moved the 1 and 2, number 1 and 2 forward, yes.
forgot we weren't running our own business here, I'm
Yeah.
sorry.
So where is the staff report to the board for these agenda items? Like a page in this portal?
Were these uploaded into the portal?
To that.
Can we get some copies? Yeah.
I thought it was just me.
Okay, no, I'm clicking through all the pages saying,
Just me. None of your presentations in here. Your placemats
the
are.
placemats are here, but
Your other stuff's
I
not.
can't speak to that. I don't know why.
Anything we need?
I mean, well, it's not end of the world deal, but like, we just approved an art consultant, and typically the staff report to the board would tell us how much money we're spending on that and things of that nature. And
We,
Yeah, so our consultant, again, we don't know the dollar values per project until we get into the projects. Yeah, it's not a.
just the award of
Yeah,
the
these are just,
services.
yeah.
Consulting. Same with the A&E. There are no dollar values associated with
Okay.
that.
We've not put these in traditionally. In the packet, okay.
Okay.
if you have some in-depth question, we can move it into closed.
That
We
just,
have one more before then.
I'm clicking around looking for information that apparently is not here, so.
Adam, for the A&E, there were two choices.
Yes, sir.
Were they ranked by your team?
They were ranked by the scores, yes.
Okay, and you listed them, are they in the order you just mentioned them? Because we don't have it in
Hoffer-Wilker
writing.
was one, and Perkins and Will was two.
What was the first one again?
Hoffer-Wilker,
Hoffer's 1 and Perkins is 2.
yes, sir.
Okay. No, if no more discussion, entertain motion for approval.
Move to approve.
Need second?
Second.
All in favor, signify aye.
Aye.
Any opposed? Motion pass. Next one, please.
The next one is for the CMAR, the construction manager at risk, the contractor for the medical office building. We had 4 respondents. The 2 that were shortlisted and interviewed are Austin Commercial and J.E. Dunn. Again, they both exceeded our range, and again, these are projections by the contractors until they bring the subs on. Both were in the 25 to 35% or 30 to 38% subconsultant or subcontractor range. So pretty significant for us. So we're very happy with that. The scores were exceedingly close for both of them. 3 points separated them. So again, we recommend 2 to move forward. And again, it's CMAR, so there's a dollar value initially for fee and general conditions being a percentage until we have the actual construction cost. And there's also the pre-construction dollars that they bid on directly initially, and those are limited dollars.
Can you give the names of the contractors again, please?
Austin Commercial and J.E. Dunn,
Okay.
and they're both exceptional firms.
You've worked with both of them?
Yes. Many times.
Is this another case where we're sending 2 to the court?
Yes, sir.
Austin is doing a project now, aren't they?
They are not. Neither of them are doing a project for us right now.
Any more discussion? If none, I'll entertain a motion for approval.
It's going to look like only Rev and I are at the meeting here if we keep going.
It's going to be Zoom.
Move to approve.
Second.
All in favor, signify aye. Any opposed? I guess motion pass.
I have a question.
Yes, sir.
When we send these forward to the Commissioners Court, will the board get feedback? Somebody that's not on what we sent forward?
They usually let us know.
I know. All the things that haven't happened to date that all of a sudden do.
I think they want that option, but they have not exercised the option.
I hope not.
It's a lot of work.
But we only send, do we send the whole packet or we send just these?
Just the 2.
Just the 2.
We send the top two, we also send the.
We send the whole.
Stuff like that.
They see everything.
Yeah.
And I do have some additional instruction for the committee enclosed.
Okay, thanks. And then D will go into close. We're just going to go ahead and go through the whole finance, and then we'll do both
Yes,
in
sir.
close. Thanks, Adam. Before we get started with the finance committee
Thank you.
section,
Thanks,
Would
Adam.
you like to introduce a new team?
Yes. Ashley, you want to come forward? I would like to introduce Ashley. You can go ahead and have a seat there. You can get used to having to come forward before the board. Those seats are hot seats there. But I'd like to introduce to the members of the board here Ashley Ridgway Washington, who has honored us by joining us as the CHRO of the organization. Ashley, would you tell the board a little bit about you?
Good morning, all. My name is Ashley Ridgway Washington. I am what I refer to as a reformed attorney. So I am barred in the state of Florida, but no longer practice. Really passionate about people and culture, and have spent the last 12 or 13 years in progressively strategic HR roles. Most germane to my work at JPS, I spent roughly 8 years at Christus Health. I served in various HR executive capacities, both in the acute, post-acute, and corporate spaces. Most recently left Amazon, where I led globally their employee resource groups, and am just delighted to be here with the JPS family. Delighted to be back in healthcare.
Do we get additional discount from Amazon?
Did we get additional discount?
Employees do not, so we don't either.
Oh, well,
Thank you.
welcome on board. And I would like to invite our CFO for the CFO report. Welcome, Sharon.
Good morning.
Good morning.
I do have just a couple of things I want to preface before we start the financial report. You will be receiving a mail out next Friday for your board meeting that's upcoming, and that will include the budget presentation. As always, I am available for all questions and will be happy to answer anything. I think in prior years, DT asked that you kind of funnel all questions through him, but I am available to answer any of those and would appreciate any feedback prior to August 10th so I can bring the information if you do have a few more details that you would like to see on that. So again, on August 10th, at the next scheduled board meeting, there will be some significant time to follow up on our board retreat from last week, where we can actually recommend approval for the budget to the Commissioners Court for their final approval. I'm going to go ahead and go into our financial report for June. We really had a strong inpatient admission month again. This has been pretty consistent for the last 2 or 3 months, and we are on budget with those. Our length of stay has been very consistent. I will point out that red line for budget did drop. We really thought that we would see a little bit more impact from that transition from inpatient to outpatient, and the coding in some outpatient back to inpatient. But our length of stay has been very consistent this year. Our outpatient statistics, the emergency department has been as busy as it ever has in June. Even with these high volumes, are left without being seen is about 3.5%, which is a great number. This was one of the busiest months of the year. If you look at June for the 30 days, we had over 360 patient visits on average for the entire month of June. Our urgent care remains pretty constant for this year, above our budget. And then our primary and our specialty clinic visits, both of those hit budget this year. We'll expect those visits to continue to rise as some of the provider vacancies are filled in both of those areas. From From a surgery standpoint,
I have a
we
quick
have.
question for you.
Oh, I'm sorry,
Sharon.
DT.
For the urgent care clinic,
Yes.
are those most, can you give us a little bit of visual into the payer mix for urgent care? I'm just curious to see, are they majority JPS connection or they have third party type thing?
I have not looked at the payer mix specifically for urgent care. I can do that and bring it back. My suspicion is it follows pretty closely our overall 60-40, where 40% of our patients are unfunded.
Okay, all right, thanks.
I'll follow up, and if that is any different, I will let you know.
Okay, thanks.
For surgeries, we are really reaching capacity of our ORs, but we do continue to stay at a very high level. Vascular, ortho, and podiatry are very strong. And also trauma increases in the summer months. So we do have, again, very strong inpatient and outpatient volumes this month. Behavioral health continues to pretty much stay right at their capacity, especially on the patient days. Kind of the numbers that are buried in here, we have reduced our average length of stay for behavioral health admissions, which allows us to push more folks through our facility. We have had about 420 additional admissions and discharges for behavioral health this year. Our emergency visits and our clinic health visits continue to be high and pretty much along with the prior months. We did have a question around our occupancy, which is the top right graph this month. We continue to experience in excess of 90% occupancy. When you consider cohorted patients as well as bed turnover, you can never get to 100%. And from my experience and industry standards, anytime you're above 75%, things start to get pretty tight and challenging. So those are beds that are pretty homogeneous, and we're able to reach that target. But we have really tried to maximize all the beds that we have, especially with the throughput.
How have we increased the throughput through the beds? I mean, doesn't that depend on the acuity of the patient and what's going on?
It does, and
Why haven't we done it before? I guess it seems strange.
Well, there's always challenges, especially with the population that might be there. I think if you could, and I'm speaking from what I've heard that's happened, but if you can start to forecast and really work on discharge earlier in the patient's stay, often that will get that going. Making sure that our ancillaries are coordinated and you're not waiting on a test to discharge a patient, making sure that they have their meds ready for discharge. So it's a lot of that care coordination that we've been working on for several years. And it's a very difficult process. There's a lot of considerations that go into that. Yes, sir?
Yeah, Sharon, just looking at all of these charts, can you in general give your opinion as to whether being over budget or under budget is favorable for our finances? You know, looking, it may be different from chart to chart.
Let me give you an overall answer first. I think from our mission standpoint, getting as many patients through is always advantageous. When you look at it from a financial standpoint, because of our payer mix, Again, 40% on average not having funding. Often when you increase your volumes, it will actually lower your bottom line. I don't know if that answers your question.
It
but
does,
I
it does.
can't say it's a good or a bad thing, but
Well, I'm talking about dollars. And are there some of these charts where being over budget is a good thing financially? Knowing the payer mix?
once you have, and so from my standpoint, it really depends, again, on each individual service line and the contracts that we have in place for those that do have a payer source. I will say that we really have, again, an overarching, we've got so many fixed costs in the facility. So when you look at healthcare, even though you look back and you say, well, gosh, we may have lost money on a particular service line, that incremental volume that you add can add a contribution margin. So just the variable cost or for the next 10 visits or the next 10 admissions can add a little bit to your bottom line or even break even. So I can tell you that the facilities that we have, we are utilizing pretty much the most volume that we can push through. So it would kind of depend on that specific service line, but I will say, you know, we talked about this a little bit on Friday, where a lot of the average patients we're not making money on, but once you cover your fixed costs, that incremental volume, you may break even or make a little money on. And again, it would depend on what mix of patients that are coming through in their payer source.
That would be true if you're allocating fixed costs, you know, to each service.
Right.
Do we do that?
We do. Our cost accounting, when we look back, includes all the previous volume, and it would also push out all of those fixed costs of facilities and overhead. And then when we evaluate new services, we evaluate those more on incremental volume and go look at that contribution margin that may be added.
Okay. Well, it would be, I think, helpful for me and probably for my colleagues when we're looking at these charts to know which ones, when they're over budget, actually is helpful for our budget.
Okay.
You know, if it could be trauma, for example, or outpatient surgeries. There could be some of these that it's, from a budget perspective, is a favorable thing.
Right.
Because when you say budget, you're talking, you do a budget of quantities, of volumes.
We do.
That's not just the dollars, but the volumes in each of these areas. And then you compare your actual to what you budgeted. And then from a financial perspective, I'd like to know, when is that a helpful thing and when is that a harmful thing?
And the difficult part of that is a lot of the revenues that we receive from supplemental funding might be based on volumes from 2 years ago. And so that's always kind of on a 2-year lag when they pull our reported numbers for uncompensated care. So it is kind of difficult to get a true matching, but let me think about that and see what I can bring back. On the financial metrics, I did want to spend a little bit of time on our payer mix chart. A couple of things are going on there. It is not unusual for us to have a higher self-pay during the summer. We do get a lot of heat-related activity and a larger number of self-pay from a seasonality standpoint will hit during the summer. The second thing that we have going on this month is that we are experiencing the Medicaid unwinding as Medicaid patients begin the re-enrollment process over the next 4 to 6 months. Medicaid kind of kept everyone on through COVID. they extended that reapplication process, and the first group is really starting to go through that currently.
Are we allowed to provide assistance to help people stay enrolled if they just need help with the process?
We have a whole team built from an eligibility standpoint that if we are here to assist. We go through the ACA criteria, Medicare, Medicaid, larger grants, and we try to find each and every patient coverage. And then we will also look at their eligibility for the Connection program. So we're very active in that. I think one of our challenges has been from an internal perspective is that Medicaid will not provide us the role of people who may be exiting the program or up for re-enrollment. So we're really trying to communicate with our population, those that have already been accessing care at JPS, to re-enroll. We've had some MyChart communication, which is our electronic medical record. We have for those that are on Medicaid currently.
If they show up for service and they haven't re-enrolled, is that too late at that time?
No, there's retroactive coverage that we can go back, I think 60 days, 90 days. We try to match what Medicaid will provide. So if you're inpatient, if you come in through the ER, you're identified as a self-pay, there are resources that are actually there on site to try to begin the enrollment process. If you happen to be admitted and you're on a patient floor, you'll receive a face-to-face visit from someone from eligibility. It's not necessarily a social worker, it's more the financial eligibility side. They will speak to a social worker, but that's a separate team.
Okay.
Yeah.
Thank you.
Sharon, go ahead, Reverend.
No, I would just say for Blake, if there's in an area that's thorough, that is a thorough area that Sharon's staff does perform, because I have that experience of many who are here. I've seen where they forgot to re-enroll, didn't know how to get back in, and that her staff has done an excellent job of reaching out and getting those persons taken care of.
Good.
Thank you.
Sharon, can you remind me, if for connections, did we still do the 1-year eligibility renewal, or did we move it to 2 or 3 years?
It's still 1 year, which is the process for Medicaid.
Yeah, I know we talked about it during COVID. I'm moving that to 2 or 3 years since we were losing so many people. Because from last year to this year, we've lost an additional 1,600 individuals off of connections, and that can be for a multitude of reasons. But as we know, poverty doesn't move as quickly, and that is always a contention point of where we can help our patients with not having to prove up their documents every single year, moving that to a 2-year or 3-year process, just to kind of help keep them on those rolls so that they don't feel like when they look at MyChart and MyChart gives them that big outstanding balance notification, they don't get afraid to come in. I think that's where we're seeing a lot of individuals not come in because of that movement. I know we talked about moving that off of MyChart as well, lower down, so that that's not the first thing that they automatically see. I understand the psychology of the money, but we also want to make sure that they're coming in. That's not one of the reasons that they're impeding of it coming in.
Is there a difference to the hospital or to the patient, whether they're in connections or self-pay? Do they get the same treatment? Is there some sort of medical coaching going on if they're in connections?
Yeah, so from a connection standpoint, that gives them a primary care physician who can kind of help navigate. It also has a prescription drug program. There's very small co-pays associated with some of the connections. So although it is not a health plan, it will operate, it operates much like a closed network. And there are navigators that are available for a connection patient. The self-pay that we see are typically, there is some payment from our self-pay, although it's very small. They will typically access through the ER, and sometimes you're admitted, so that's where a lot of our self-pay balances come from. The other access point is at a community health clinic.
So with connections, there's going to be some managing going on to try to reduce problems and reduce costs.
That's a lot of the population care that we discussed on Friday. The other thing, if you are self-pay, there is a very large discount at time of billing if we have not identified insurance. And we also have presumptive charity where we can run kind of public information. And if you qualify, that might even qualify you for up to an 80% discount on your bill before it goes out. So we do try to preemptively identify patients who would be eligible for connection. But if for some reason you don't apply or you're not eligible, there is a large discount that is applied to your bill.
Okay, thank you.
And if I'm not mistaken, that's also the holding place until they qualify for Medicaid and other program, SSI and all that stuff also as well. Right?
Yes, we do have a lot of robust work going on for patients that may be Medicaid eligible and have a few firms with expertise that really goes through that complex process with them. But that's part of the eligibility screening that I talked about a few minutes ago.
So if you're eligible for Medicaid, you can't be on connections?
That's correct. Yes, a connection would be kind of after, if we can get you signed up for ACA commercial plan, we will do that. So the screening goes through all available sources, and then if none of those are available, we'll check your qualifications on connection. Yeah. And about half and half, as you can see by the payer mix.
Yeah. And a lot of time we have to classify them as so that they can receive a statement, so they can give us additional insurance. Sometimes they hide the insurance until you send them a letter type thing.
Really?
It's typical.
Why would you hide insurance?
No copay. And then, or they qualify for other program, but they don't. That's when they cooperate and give you information so you can apply for them on their behalf. So, okay. Thanks.
For the month of June, we had a very similar month to the rest of this fiscal year. You can see that we closed the books ahead of budget at $26.9 million. Again, a lot of this is related to strong volumes. You can see the net patient service revenue above, which is offset by a lot of the supply overage as well as the salary overages. Those salary overages, when we flex to our actual volumes, were actually favorable to the dollar budget, even though that fixed budget shows that we are over about $4.5 million. The one thing I did want to update you on this month is we recently found out that we are going to receive some additional dollars from supplemental funding. We always talk about that HHSC only pays those amounts once or twice a year. It is above where we had budgeted and have been recognizing them. So you see the supplemental funding from Medicaid is over about $13 million this month. That's a combination from the HARP program as well as our DISH program. Again, most of that information, it depends on the pool size that gets allocated to Texas. The pool was larger. It also depends on Within the state, we have 5 different pools. We sit in the large public hospital pool. So within the state of Texas, our pool got allocated more dollars based on our uncompensated care numbers off of our cost report from 2 years ago. And then it gets divided between the 5 large publics here in Texas. So there's a lot of factors that go into some of the supplemental funding. So you'll be seeing that will accrue it equally all the way through the end of this fiscal year. And then next fiscal year, we are expecting some decreases that we had talked about on Friday in the supplemental funding pool line item of about 45 million next year, a decrease. So,
So is this a one-time bump in supplemental funding that we won't see in July, you think?
no, as I indicated, you'll see that 13 million overage for the rest of for the next quarter.
Okay.
So that when I close the year, our accrual will match that notification that we received a few months ago from HHSC. I'm sorry, a few weeks ago from HHSC.
So will you adjust the budget for the next year, anticipating the higher volume?
So next year, our budget is probably not going to change from Friday because the decreases from this year to next year are around a legislative decrease in the pool size, as well as the removal of the benefit that we got from the higher federal match percentage that goes away with the public health emergency.
So your budget will be closer to the 15 million per month?
Well, the 15 or the
14.8 for supplemental funding.
I'll have to look at that on a monthly basis, but as a total basis, our supplemental funding is decreasing, I believe, by
50-something million.
yes,
Yeah.
by about the 50 million.
And that's taking us back to our traditional baseline prior to the bumps we've been getting the last year or two?
Correct. Yes.
It's not
And
really a decrease,
based on-
we're just the extra money's ending.
Yes. The next page that I have here is our projected income statement for the year. I wanted to take a minute today to go over that in preparation for the presentation of the budget on August 10th. Where our projected number is, which is that second column, we expect to end the year at about $166 million. That basis will be what we compare the budget 24 to. Again, there's kind of a few stories that has created a favorable year to budget for us. We have had some additional volumes that have gone through. Again, the HARP program, we did not budget for that as HHSC had not finalized that program, and that will be about $45 million at the end of the year that was not budgeted. And Blake, the HARP program is budgeted for next year. And then, just from a overall standpoint, our investments have done much better than we anticipated. Hilltop comes once or twice a year to educate you. We are on very limited options for what we can invest in, and no one anticipated that the interest rates would be raised to the degree that they have during the year. So we have picked up quite a bit on that investment income line as well. Are there any questions from the financial presentation? Okay.
Nope. Thank you. Let's move on to the next section.
Well, we do need a,
Oh, we need approval.
yes.
You have a motion
Thank
for
you.
approval? Second, Zim. We only have 2 active members. All in favor, signify aye. Any opposed? Motion pass. Next item, 7A, consider approval for, oh, that's one we just did, I'm sorry. Item B.
So this contract is for Spivey Health Policy. Speaking of supplemental Medicaid funding and the complexities that we deal with, Spivey has been associated with JPS for a very long time. They assist with all of the programs, DISH, UC, CHIRP and TIPS, as well as HARP. And we are asking for a 3-year contract, as well as an exception to bid for a professional service, $235,000 a year for a total of $705,000 over the 3-year period.
So going forward, we can do exemption to bid for this one?
Right now, our procedure does say that any, even if it's statutorily exempt, we'll bring those and we can update our procedure.
Okay. Just the reason I asked that question, because we approved twice before. I think one in 2021 and one in 2017 or something. I forgot what it is.
I don't know the dates.
And
3 years ago.
It was under professional services, so we didn't have to, but I think.
It may have been a
legal
change in philosophy, so
philosophy.
there's a, statutory exception to bid for professional services, and so may not have required any approving.
So that's when you see the exemption to bid on that one. Any question? Any discussion? If none, and entertain motion for approval. Zim? Second by Robbins. All in favor, signify aye. Any opposed? Motion passed. Thank you. Item C. Good morning.
Good morning, members of the Finance Committee. I'm here today for your consideration of approval of an Uber Health contract between JPS Health Network and Uber Health. The cost is approximately $420,000 annually, which is included in the approved operational budget. Potential cost over a possible 5-year term with initial 3-year plus 2 1-year renewal options would be $2.1 million. The Uber Health contract is not a behavioral health contract. I wanted to make sure everybody understood this was district-wide. It provides non-emergent and non-ambulance transportation for our uninsured patients and our JPS Connect patients so that they can go to their cancer center appointments, other outpatient appointments, primary care, in order to reduce their potential for having to use more urgent or emergent services here at the hospital. And it helps us meet our mission of providing access to care and leveraging technology as well, because we are able to utilize Uber's dashboard in order to be able to track and trend and manage the dollars appropriately.
Hey, Zelia, I know that when we started this particular program, we talked a lot about the tracking of it. How, over the last couple of years that you've been utilizing it, have we seen patients move through the program itself, be able to have their utilization of it? I know we were looking at they could potentially also, go to a pharmacy or go to a grocery store. Have we heard or tracked those patient stories or things that they have?
I'm happy to bring back some of that. The answer is yes, we do. We have all kinds of data, like in particular zip codes and places traveled, like you said, pharmacy, grocery store, those type of things. So I did not bring that with me today, but I'm happy to discuss that whenever the time's appropriate and bring that data for the committee.
So are the transportation services limited to healthcare needs, or is it?
They are, but you're allowed to input a stop. So if our social workers in our clinics or the hospitals, if we know a patient needs to pick up pharmacy, their medications, we can put that in the Uber stop so they can get to their pharmacy to get the medications, because that's also important for our patients to be able to get that. Or many of our uninsured and connection patients also are food insecure. And so if we sometimes are able to assist with that as well.
So do we set up the ride and the stops?
We do.
That's controlled by JPS?
Absolutely, yes.
Interesting.
Yes. And the access to the entire system is very controlled as well. So it's inpatient case management, outpatient case management, and that are able to order that.
Before we started doing this, and this may be an Amanda question, how did people get here?
So access was very limited for things like that. Before we implemented Uber, I guess 3.5 years ago, we primarily utilized Yellow Cab, and that was straight from here to the house, but it was not the best utilization for our patients.
Basically taxi vouchers that were ripe with fraud, waste, and abuse.
Yeah.
Yeah, and we weren't able
Not on our
to,
part,
Yeah.
the tax. No.
not able to track, the,
Yeah. We had no tracking mechanisms at all when we were utilizing the taxi service. And so this,
Wherever you want.
But you can go to the pharmacy and JPS would set up that ride. So has this decreased the burden on our paramedics that we're giving people rides for non-emergency issues?
well, I mean, previously, before we were using Yellow Cab, and so that burden wasn't placed on EMS
Non-emergent.
and those non-emergent, that wasn't placed on EMS like that. What this does, number one, it's cheaper than what we were doing before, so we actually created cost savings. But number two, it does allow us to have a closed access and be able to monitor the usage appropriately, and then have those planned stops, on an individualized patient's care plan, pharmacy or a grocery store, something like that.
So I was told a long time ago by a Fort Worth fireman paramedic that the fire department was being used excessively for non-emergency runs to get prescriptions and things. I would think that this service that JPS provides would help reduce that misusage of far more expensive transportation.
Well, it should, but I'm not aware of that.
or recently, just about some programs, even for those non-emergent, as you respond to a patient who really does not have an emergent visit that needs transport to the emergency room or to the hospital, is how we might be able to divert that to one of our community health centers to take care of a prescription need or non-emergent need. As you were asking that question, which was a great question, I was thinking through how do we look at the downstream to your question, advantage as far as cost,
Right.
to use a fire department or to use an EMS service. So we can work with them as to whether we can quantify that downstream.
Hard to
but I
now
would-
if we've been
yeah.
doing it for several years, but this is an example. We're spending money from our budget that's benefiting the whole county,
Correct. It potentially has that. You're absolutely correct.
Yeah, typically, we're talking about two different types of services here. This service is strictly to support the patients of JPS. I don't know of any case where a fire department has transported anybody anywhere. If it had to happen, it was MedStar that did that. And when I was chairman of that, that's one of the things we worked on, was trying to make sure that we weren't just being an ambulance bus service. But they're really two different things, and I don't think we want to try and mash them together.
I think it's also important to notice that Yellow Cab don't have the proper training. These are former first responder or somebody who as a driver, right? So they can provide certain emergency, what do you call it?
Or at least they've had first aid training, or
First aid,
things
yeah.
that they recognize signs and
The
symptoms.
Uber drivers, because it's through their Uber Health division, and so they
These
have additional.
wheelchair accessible vehicles?
Some of them, if a patient can ambulate themselves from a wheelchair to a car, they'll put the wheelchair in the trunk. But if someone's completely wheelchair-bound, then we have contracts with other non-emergent providers, such as Netty, in order to not have to call an ambulance or something more expensive.
Uber doesn't handle that kind of a.
Correct.
Right, okay.
Okay. This also gives us opportunity under the umbrella of Uber Health to be able to provide the patient service to anywhere in the county. Whereas if y'all used to have a contract with the T, or provided bus passes from the T, or being able to give those out, but that is a Fort Worth city limit. With Uber Health, it allows it to go out to the county. I would like to see, like you said, with the zip codes, where that utilization is coming from, especially when we're talking about other cities in Tarrant County that do not provide public transportation, that it takes it so long to get there, or to move through. And so this provides that
I
opportunity.
think you start seeing the transformation of us into population health. Whereas, we can get them here on time so we don't waste time for clinician, very high salary people waiting, and they may have cancellation, all sort of things. Discharge can be faster so they can go home. Otherwise, so we can expedite that process.
Yeah, I
At the
agree.
same time, we'll be looking at somewhat of a social determinant of health. How do we play in that arena from a funding perspective as we move closer and closer to full risk type thing or value-based care type thing? So it's a lot of work that I think when you see some of the philosophy and strategy around budgeting from IT and from where Dr. K and from the nursing area, I think it's not coming to life. It's early stage, but I think it will give us a lot more data down the road to planning. I think.
So this isn't a behavioral expense. How are you dealing with this?
She's doing off-balance sheet financing for her area.
We utilize this as well. However, I'm presenting it because I'm lucky. So initially, when we went out for RFP, my team members were like the lead on preparing the RFP and also helping implement Uber district-wide. And so it's just kind of stayed with us as far as continuing that process.
And the cost is variable depending on volume?
Correct. However, this cost for this contract is based on current volume and projections for FY24.
I'd say this is a very successful thing in my view, because the yellow cab bus voucher system didn't work for us. It's able to get people out of the emergency department and home, whereas they would stay overnight waiting for a safe discharge or a ride. And so it's been really invaluable to us, so thank you.
Yeah. Second.
Oh, we have two other member.
No cookie for you.
All in favor, say aye. Opposed? Motion passed. Thank you. Next one.
Thank you. I'm here to ask for your consideration and approval for a software service agreement between Green Space Mental Health and the Tarrant County Hospital District. It is $132,000 annually, which is included in the approved operational budget, a total cost of $660,000 over a possible 5-year term. That would be an initial 3-year with 2 1-year renewal options. This allows us to leverage technology to provide measurement-based care in our outpatient clinics. And so what this means is we will have, so for behavioral health, our patients, when they come in and we ask, how are you doing, et cetera, that's the feedback we get. as a clinician to make changes, et cetera. And so what this software will allow us to do is use evidence-based screening and assessment tools the minute a patient shows up at the clinic, every appointment, and it assesses the patient's progress in treatment at each appointment and over time, and this automatically goes to our clinicians within our Epic system, so our clinicians are able to see a patient's progress throughout the course of their treatment, and if they're not progressing, it's clearly right there in front of you that's data-driven, and so then this allows the clinician to make changes within their treatment in order to improve the self-reports from the patient that they're improving in their mental health, whether it's depression, anxiety, panic disorder, or things like that. And so, and we will have the ability to send this out via MyChart, text message, and email, and it will be branded as JPS Health Network. And we're excited about the potential for this.
So this is a new software,
Yes, sir.
and then it integrates with Epic.
Yes, absolutely.
So for 5 years, 132,000, is that, that's not a perpetual license? I guess we're just getting 5 years
Yes,
of
sir.
licenses, and then you'd have to renew it after that?
Yes, sir.
If you don't,
Unless Epic, in the meantime, comes up with something similar within the Epic system, then we would not renew.
then it would be 250,000 a year probably, so. But the cost is, if you've got a 30-day out clause,
Yeah.
what would cause you to want out?
Service.
Service or it not doing what they say it was going to do, although we've had multiple demonstrations by multiple companies, multiple opportunities to ask questions and those type of things. So we're pretty confident in their ability to deliver. They're also a small company, so their responsiveness to us has been extremely quick, and we're confident that it will deliver.
Do we have, I'm assuming we have assignment clause and all that stuff, just in case.
A what?
The assignment clause and all that stuff, just in case they've been bought out,
I would,
probably. Is this bi-directional API or just one?
buy.
Okay. Are you okay with it, Will? Okay.
Oh, trust me, Will's team's already, they were in it from the beginning.
Want to make sure. Any more discussion? Otherwise, entertain a motion for approval. All in favor, signify aye. Any opposed? Motion pass. Thank you,
Thank you very
Zelia.
much.
Good luck with it. Welcome, our
morning.
Chief Nursing Officer.
Hi there. I am here asking for your approval to purchase a purchase agreement with Intuitive Surgical for the ION system. This system will allow for robotic-assisted, minimally invasive lung biopsies, essentially providing interventional procedures for patients with lung cancer lesions at earlier stages of disease. And so we know lung cancer is super important to get the disease early to ensure better patient outcomes. The total cost for this system, including some supplies, are a little over $650,000 and is approved in our FY23 capital budget. I will also note Dr. Patel is the only trained pulmonologist in DFW that is able to do these types of procedures, and so we actually get referrals outside of JPS to do this procedure.
Any discussion?
So sorry, Jill, it shows that the purchase price, $610,000, there's freight, and then there's disposable supplies, and then it also says a service agreement for the equipment is also being presented, but I don't see any pricing for the service agreement.
Adam's going to present that next. He has the service agreement. It's under our biomedical department,
Okay.
Yep. So it'll come up next.
Okay, perfect.
Yep.
Entertain.
Says that's 60,000 annually? In case you wanted to look ahead.
Yeah. Is that the only thing in Adam's deal? Can we take them both?
Yeah, he has two, but
Oh, okay.
you're through. Yeah, he can come up.
He can
if you
come up
wanna
and present
Go
those.
ahead and present his.
Do the service
We'll
agreement.
combine it.
Can't really get one without the other.
Hello again. So Roger's going to present the service agreement for to Vion. Again, this leverages off the piece of equipment. The service resides within clinical engineering. It is proprietary equipment. They do not train our folks. Otherwise, we would train and service it ourselves. But since it is sole source, the service agreement is $300,000 over 5 years, $60,000 a year, 5-year agreement. And it is an exemption to bid.
I'll move approval on both items, the equipment, the service agreement, and the exemption.
Second. Second. All in favor? Signify aye.
Aye.
Any opposed? Motion, both of them pass with exemption to bid. Thank you.
Hello again.
Hello.
So here to present a extension of our lease with Andrews Dillingham. This is a behavioral health lease property. It is for $250,000 a year, $760,000 over 3 years. It's triple net lease with 30-day out clause, and it's just continued our current operations.
Entertain a motion for approval.
Move approval.
Second.
Any discussion? If none, all in favor, signify aye. Any opposed? Motion pass. Welcome our CIO. I will. Morning.
Thank you for letting me come back. I have a request today from General Data Tech, which is our value-added reseller for Cisco networking equipment, and the ask is for $713,000 for network equipment from Cisco. That includes an 8% maintenance cost for years 2 and 3, and it may seem high, that $59K, but that's maintenance for both the hardware and the software, and these switches actually are mini computers. The total then is $891K. Just to put it into context, this is 13 devices. We're purchasing 11 access switches and 2 core to edge switches. And bear with me just a second. So when you think about switches, there's really, think of it as 3 tiers. There's core, which is the brains of communications, internal and external. There's the access, which is really responsible for, as it would imply, access to the brain, and then distribution of traffic. And then you have your core to the edge, which is last mile to the device itself. All 3 of them deal with traffic security and quality. But the closer you get to the core, the more sophisticated, and we usually bring in resources to help us with it. That's important because somebody's going to ask me the question, here we are 2 months away from the end of the fiscal year, why are you buying the equipment now? Well, I'm buying the equipment now because the 9400s have a 217-day lead time. So a significant lead time. The lead time was even longer. The other models have a 57-day lead time. The access switches, the 217-day lag time, we're going to be buying some more next year. It's really an issue of economy of scale. What I'm trying to do is push this off a little bit so I can get it in mid-year of '24. As soon as we come into fiscal year '24, come back with an ask for the others, because Cisco will manage in 2 ways. One, if they have the equipment and they take pity on institutions, hospitals in particular, and try and move and reallocate their resources. In this instance, since we'll be committing to 11, they will commit to the 11 and anything else we need to get us into that 217 days. That's important because I go back to the sophistication of the switch. We bring in external resources to help us. So it's really economy of scale. If I can combine the 2 and bring them all in the same time, I have a less of a cost when I bring in the external resources to do the work. So that's why we're bringing it in so late. It's really just the logistics of trying to get it all done. Any questions?
The 59,000, is that like my maintenance plan?
Yes, sir. And that's the maintenance for both the hardware of the boxes themselves, as well as the software inside the box to manage the traffic, to deal with the security, and deal with quality management. So again, that software that we're paying for looks at Is it the right people? Internal security, is it the right people? It measures the quality of the traffic communication by dropping packets. So there's a lot to that software.
And is this the managed service by Cisco, or is it through your own team?
So this is, the delivery and the installation will be through a combination of both GDT and Cisco. Cisco will be involved when we do the access switches. GDT, we basically do the edge switches, and GDT just drop ships.
Drop ship? And then...
And who monitors these? Is there an outside monitoring firm that's like a SOC or something, or is that?
So we have our own network operations center, and we monitor our traffic. We're getting better with that and investing in the people resources to be able to manage that and monitor it on a daily basis.
Okay. The 59,000 is if something breaks and updating firmware and things like that?
Yes, sir. Yes, sir.
I don't think any one of us qualified to ask any more questions, so I'm entertain a motion for approval.
Move for approval. Second.
All in favor?
I was wondering when we were going to approve the contract for Will Security, so.
This is your one. Thanks, Will. And at this point, we don't have anything in open session, so we're going to take a 5-minute break and go into closed session. It's 12 o'clock, and we're going to go back to our open session. We're going to discuss two items that were outstanding. One, we did get an update from our general counsel on the insurance update, and the other one is the approval for the item that we discussed in the closed session.
It's J.E. done.
All in favor? Any opposed? Motion passed unanimously.
Thank you.
That will include our, yes, sir.
Yeah, you should. The red folder should always be left.
Yeah, the red folders remain, yes.
All right.
We haven't had any of those walk away yet, but they're real good at wiping real quick.
All right. With no further business, the meeting's adjourned. Thank you, sir.
Thank you.
I tell you, right to the minute.